Thanks, Anjali. As you mentioned, I am here on behalf of the New South Wales Smoking Cessation Collaboration to do a bit of an introduction to the New South Wales Smoking Cessation Framework. So I might just briefly start with who the collaboration is. So the New South Wales Smoking Cessation Collaboration was conceived to support the capacity of the New South Wales health system and community-based settings to embed brief intervention in smoking cessation as part of routine care, with a view to making smoking cessation everyone's business. Under the New South Wales Tobacco Strategy and the New South Wales Cancer Plan, the collaboration contributes to implementing the delivery of routine brief interventions in smoking cessation through leadership and coordinated action. One of the key activities of the collaboration is the development of this framework. I've got the membership up on the slide there, but broadly speaking, it's the New South Wales Health Pillars, the New South Wales Ministry of Health, our key colleagues in NGOs, being the Cancer Council, Aboriginal Health Medical Research Centre, and also counterparts at the University of Newcastle and Primary Health Networks. I think I've covered everyone there. So I can't do a presentation without putting up some stats about why we're here and that smoking is bad. But we know that the smoking rate in New South Wales for 2016 was 15% for the general population. And we know that smoking accounts for 5,500 deaths per year, 47,000 hospitalisations per year, with tangible social costs estimated at almost $3 billion per year as well, just in New South Wales. So tobacco smoking is a leading cause of preventable ill health and premature death in Australia, and is a major risk factor for coronary heart disease, stroke, many cancers, and a variety of other diseases and conditions. So smoking is bad. So smoking cessation and health services. Health services are uniquely placed in that they provide an opportunity to engage with people who are smoking. It may be one-off occasions of service, but often, particularly within cancer services, there is an ongoing relationship with patients. And so, because quitting smoking can increase life expectancy by up to 10 years, and for the reasons listed here, it makes sense to support... Is it? What's God going to say? Might be next door, and I'm sure that's equally or otherwise important as well. But it might be my cue to move on to the next slide. Okay, so I'll get on to what the actual smoking cessation framework is and does and how it was created. So we reviewed evidence. We reviewed a study that the New South Wales Ministry of Health did in 2016, where they consulted with districts about what were the barriers and enablers to smoking cessation interventions within their settings. We reviewed the evidence more broadly around systematic enablers for smoking cessation interventions, and we also reviewed some of the more successful practice change initiatives in New South Wales, such as hand hygiene. And we also consulted broadly. So we consulted with key stakeholders, so all of the membership of the collaboration were consulted. We consulted with directors of cancer services, we consulted with population health services, with mental health services, drug and alcohol services, to really create a framework that would speak broadly to the New South Wales health system. We also spoke to junior medical officers who were really enthusiastic about smoking cessation and the opportunity to incorporate them in whatever our plans were, but they were also really clear that they are the future of health service delivery, and what a great opportunity to engage them at this point in time. So the key enablers that were identified through the review of evidence and also via consultation are broadly listed here. I haven't listed the barriers, but I will name some because they're probably quite familiar, and it's worth acknowledging that they do exist, because otherwise you might think, but where were they? So they were insufficient training and resources, demands on time, stigma and discrimination, relationships with patients, staff smoking, and insufficient data collection or feedback. But the enablers are here too, and so they were loosely around leadership of senior management and executive, having champions in place within different settings, implementation groups, data, local KPIs and audits, and training and resources. So some of this is starting to sound pretty familiar from what Graham spoke to us about this morning in the panel discussion as well. So now we have a smoking cessation framework, and the framework has been built to leverage off those enablers from the last slide. The framework the aim of the framework is to support local health districts to better implement smoking cessation interventions. The framework is broken down into 4 implementation strategies, and I'll go through them in more detail in the next slide. Each of those implementation strategies has several actions, and the idea of having those actions is that local health districts, whether it's the whole of the organisation or whether it's cancer services specifically or antenatal services or a hospital more broadly, might be able to pick them up and plug and play for their setting. So knowing that they've either got strong leadership or they've got some really good data work that's happening, that they can pick those elements up, those actions, and put them into action within their setting. The framework also identifies some of the key resources that are available to support the work, so clinical guidelines, tools to guide practice that have been developed by the New South Wales Ministry of Health, icanquit.com.au, and the New South Wales Quitline. There are also within the framework key success factors to enabling this work to happen. And it's kind of those that I want to focus on, but I can't go into that without going into each of the implementation strategies first. So, the implementation strategies are here. So the 4 strategies are around providing leadership and governance structures, and some of the actions that would be involved here include appointing senior executives to implementation working groups and into governance roles for oversight of strategies and having ownership and leadership there. Identifying, training and supporting the workforce with actions including providing training information and ensuring consistent NRT protocols across the service or the district. Appointing a smoking cessation facilitator with actions including identifying positions responsible for facilitating implementation and enabling factors to undertake activities that support smoking cessation practice and change. And the 4th one there is around establishing accountability mechanisms. So realising the benefits of smoking cessation within electronic systems and developing internal service level agreements that include smoking cessation key performance indicators and targets. So that might look like a CE who is particularly enthusiastic about smoking cessation and making sure that there are KPIs or service measures between the executive and the hospital, or a director of cancer services putting in some sort of measures within their teams as well. So on to the success factors. So underpinning leadership and governance, the key success factors include being interdisciplinary and having interdisciplinary involvement to deliver the framework, and in implementation working groups to ensure that key clinical areas are involved in the management of nicotine dependence and smoking care. Leadership from key clinicians and disciplines could include cardiac and respiratory physicians or technicians, nurse specialists, drug and alcohol counsellors, medical doctors, pharmacists and sleep physicians, and obviously our cancer specialists and cancer services. And the second success factor to enable leadership is to ensure that there are smoke-free policies within the local health district. So that would incorporate the smoke-free grounds, which I think a lot of local health districts are quite aware of, but also patient support services and employee cessation supports. And the employee cessation supports leads well into the concept of having a smoke-free workforce. I guess people who don't smoke are going to be more likely to engage in brief intervention with patients around their smoking status. Staff should have access via their staff health clinics to free NRT or low-cost NRT, so staff are supported within the organisation as well. Equally, all health professionals can encourage patients or clients to call the New South Wales Quitline, and for enhanced uptake, health professionals can make a direct referral or can have a 3-way conversation between the patient and Quitline and themselves to kind of smooth that transition. Thank you. It's key for smoking cessation facilitators to be skilled at networking and linking clinical staff across the local health district or services or within services to improve understanding of policy and to enhance commitment to interventions. Within the area of accountability, electronic data collection is the key success factor there. It's important in establishing accountability mechanisms to enable the provision of smoking cessation care in electronic patient records, electronic health systems and clinical data systems wherever possible. In the absence of electronic systems, we would encourage systems similar to what Graham was saying this morning in terms of having colour-coded systems or some sort of system that works within that setting that enables interventions more easily. And so while there are 6 distinct success factors associated with implementation strategies noted here, there are clear links between them, and I think that we've heard how they kind of all link together throughout the discussions today and in the workshop yesterday as well, so that we have a more coordinated approach to smoking cessation in our hospitals, in our health services and across the sector more broadly. So I guess I'd like to challenge the people in the room here to think about what their role is within the framework, how they can take the framework back to their organisation to enable change to happen. What actions can they pick up? Who are the key leaders that need to be involved in these conversations? How do you use data? What audit tools are there? How can you engage with what's already happening in your local health district or within the health service more broadly to enable some change in this space? I guess in terms of our next steps for the framework, we are in the final stages of the development. We should be able to distribute the resources within the next couple of months, and we're looking at making them interactive within our website as well, so that people might be able, or organisations are able to submit some sort of case studies and we're able to share the good practice amongst the group. I think that might do me. Thank you very much.